Hi, good evening, everyone. Welcome back to another session of webinar on a Wednesday. Today we have Dr. Felix Yap from Sunway Medical Center. And of course, you all know him because we have done so many spot diagnoses in dermatology. And I think must be the 6th or 7th since I started webinar series, isn't it? A lot. A lot. And so much so that day I diagnosed a basal cell carcinoma on my patient. Did she come back?
No, she didn't come back.
But never mind, she will come back to see me because she has a pacemaker. Okay, lah, we start lah. So I don't know whether you guys know how it works, right? We put a photo and then you have to tell us what you think it is.
Can see the slide, right?
Yes, that's right.
Okay, so
Okay, start.
case number one. You see this boy, this boy came to me, I think around 2 months ago. He came to me with severe eczema, generalized eczema. So I started him on a new type of medication called JAK inhibitor. Yeah, JAK inhibitor is a type of newer type of treatment for eczema. So after around a month of taking JAK inhibitor, you can see all his eczema cleared off. You see the body don't have eczema, but it's filled with this small little bumpy dot thing. What do you think he has?
I saw Queenie.
Uh,
Come on,
what do you
somebody.
think he has?
Looks like chicken pox.
Okay. Anything else?
Eczema herpeticum. Oh, we have a lot of okay. Oh, okay. So there are many people with saying it's eczema herpeticum, which I've not heard before. Anyone else? Fiona, anything from Doherty? Okay.
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 So I think most of them get it correct, like eczema herpeticum. So when you start a new medication, JAK inhibitor in patients with eczema, so they tend to get increased risk of viral infection because this JAK inhibitor reduces the chance of your body against the viral infection. You can get herpes infection or you can get varicella infection. So if you haven't had chicken pox, then you might get chicken pox. If you had chicken pox, you might get shingles. And if you have a history of herpes simplex, then you can get reactivation of herpes simplex. This is a severe type of herpes simplex we call eczema herpeticum, or there's another name for it is Kaposi varicilliform eczema lah. So this is a condition in which the herpes zoster herpes simplex infection go out of control because of the eczema and also because of the immunosuppression, and it spread all over the body lah. So what we need to do is we need to stop the JAK inhibitor, and then we need to start him on acyclovir lah. I wanted to admit him that the parents is not keen, so we just start him on oral acyclovir. I think I gave him oral vial acyclovir for 5 days, came back in 5 days, everything cleared off in 5 days time. And we put him on some antibiotic cream and put him on combination of steroid with antibiotic cream to control the eczema lor. And then put him also on antihistamine. And then once the condition got better, then I put him back on JAK inhibitor. Then after restart back JAK inhibitor, he at a lower dose, there's no more attack of eczema herpeticum. Okay, so eczema herpeticum is one of the so-called dermatological emergency lah. We don't have much of emergency, not like cardiology. All their patients are emergency. But this one is one of the rare things that we might need to get patient admitted.
Oh, why is it an emergency?
Oh, because once the herpes gets more severe, the herpes can go systematically. Then they might get herpes of the brain and all those things. So we need to admit them and give them IV medication.
Okay, another thing is when you said that you treated his eczema, what
Mm.
do you use? Because I am not.
It's a new medication. We call this medication Janus kinase inhibitor. It's a new group of
Oh, I
medication
see.
that has gained approval from US and Europe for the last 4 or 5 years. I have used this for the first 4 or 5 years already, the JAK inhibitor.
And this medicine that you use, right, is not a biologic.
It's a small molecule. We call it a small molecule. Biologics is a big molecule. This is a small molecule. So JAK inhibitor is used in 3 different specialty. First used in hematology to treat hematological malignancy. This is what we call as pan-JAK. So it inhibits JAK1, JAK2, JAK3, and TYK2 inhibitor. TYK2 receptor. And then the one that we use in dermatology is usually the JAK1, JAK3, or specific JAK1 inhibitor. So these are more specific for dermatology. The dermatology one, it can overlap with the rheumatology one that is used to treat rheumatoid arthritis. So this JAK inhibitor also is used to treat rheumatoid arthritis. So in patients who haven't have chicken pox or who had chicken pox and you are worried about reactivation, we usually recommend immunization before we start this medication.
Oh, I see. Because there's chicken. If we see, okay, somebody asked if we see this issue in primary care, can we advise to take off jab and start acyclovir on our own?
Yeah, if you have to give the patient an option whether to refer them to a dermatologist or a general physician to admit them, or you tell them to off the JAK inhibitor and then you can start the acyclovir yourself lah. But you need to tell the patient that if things gets worse, then you need to admit the patient straight away lah. Especially if the patient has abnormal behavior, hallucinate, and then the patient cannot eat
Bad, ah.
properly, then probably you have to think about herpes encephalitis lah.
I see. And what's okay? Is JAK inhibitor or inhibitor the first
Hmm.
choice in eczema these days?
No, no, no. It's not the first choice. Is usually in the guideline you will treat it as a second or third line lah. But this patient was very severe. Being a dermatologist, we give them a choice, and this patient selected JAK inhibitor lah.
I see. And okay, now that he had this, right?
Hmm.
You change him to another medicine or
I still continue on him with JAK inhibitor. Sometimes this patient, after they clear it off, that you restart their inhibitor, it doesn't come back lah. But if you are worried, then you have to put them on prophylactic acyclovir lah. I didn't put in on prophylactic acyclovir. I just reduced the dose. Dose reduction will reduce the risk of having flare up again with herpes.
oh, you can put patient on prophylactic acyclovir one. Ah.
Especially in patients with herpes, frequent herpes or recurrent herpes, we put them on prophylactic acyclovir.
Oh, can I tell a story? Okay.
Mm.
So I'm a bad mother. So my daughter had chicken pox. Was it chicken pox? Yes. And I didn't go and take acyclovir for her
No,
because
it's okay. Children usually do not need acyclovir. Chicken pox will resolve by itself,
exactly,
no problem.
exactly that's what I thought.
Yeah, yeah, you can be
But
it can.
she developed keloid from the chicken pox scar. Oh my
Yeah, my like it's a present from the mummy.
God. I never forgave myself. But she got
Okay, the
back.
acyclovir we give cannot be BD. You have to give full dose as in like herpes zoster or varicella zoster. You need 800 milligram 5 times a day for a week.
Exactly. That's why the mom thought that 5 times a day is just so difficult. So
No,
that's why,
you can use the new one,
oh no,
acyclovir
that
H is
was
three
so
times a
long
day.
ago. My
Oh,
daughter
okay,
was
okay,
5. Now she's
okay,
30.
okay, correct,
It
okay.
was so long ago. So that's why.
It's 5 times a day. It's okay lah. Every 4 hours, man. Not that difficult.
But the mother was a very busy woman. Okay, let's go
Yeah,
on.
yeah. Any other question you want to ask for eczema herpeticum? Eczema herpeticum not only happens in patient with JAK inhibitor, in any patient with eczema who have reduced your skin immunity, then you can get eczema herpeticum. In a normal, ordinary eczema patient, you can still get eczema herpeticum. I've seen many eczema herpeticum. All right. Second, sorry. Second one. This patient comes to me like this. I think this one quite easy lah. What do you think?
Uh,
Very easy lah, this one. What do you think?
Allergic to cordial. No. Oh, contact dermatitis. Okay, okay. Maybe.
Okay, even the chairperson also know lah. The rest will know lah.
Sure, lah, it's so demarcated. It must be something that is.
Allergic to cold, Okay, so it's just to tell you that eczema do not have a specific pattern. When you see eczema, there is a irregular border. It doesn't follow a specific pattern. When you see a rectangle like this, you know that this fella probably has backache and put koyo. So you can become a fortune teller. You see, I know you have backache.
Actually, I never used the word cordial before
uh,
this. The first time ever why the word came out, I also not sure. I never
So
used
this
the
is
word in
plaster
my
allergy lah, plaster
whole
allergy.
entire.
This patient actually has backache. Then he used some plaster and caused this lah.
What the
Okay, very straightforward lah, huh?
Salonpas kind of plaster lah must be.
Yeah, yeah.
Okay.
So this patient presented like this to me. She say suddenly come out at night when she was sleeping for the last 3 days. Suddenly pop up.
This
So
one.
the husband say, you are probably bitten by vampire lah.
Okay.
So what do you think? What do you think? What do you all think? Very itchy, very painful. Very painful.
Painful.
Painful, itchy.
Hold on. Okay. Oh, quite a lot of people know if I don't know the answer, but if people say the same thing, okay, herpes zoster, Dr. Keith said, and somebody said perderus dermatitis. Okay, I don't think it's herpes zoster, that one's for sure. But I don't know what is perderus. Perderus sounds so romantic, like my dearest. Perderus, infective dermatitis, perderus dermatitis, 2 people. Anyone else? Allergic reaction. Allergic reaction usually don't cause pain, right? Insect bite. Okay. Okay, we need. Okay. we need it to be like more clinical, more scientific, or more medical, right? So if just
Okay,
insect bite,
insect bite is diagnosis lah.
is it?
Insect bite is a diagnosis. What do you call insect bite? Papular urticaria, or the most we call it insect bite. I always write in my diagnosis insect bite
Is
reaction.
it?
If you want to write, you can write papular urticaria lah. Papular urticaria is the is the is
I thought insect
the
bite is
correct thing but okay nothing wrong.
okay, okay. So I take insect bite. Then somebody say lichen planus. Dr. Key, you cannot. And of course, Dr. Key, ha ha ha, is not a diagnosis. Okay, I say it's in ICD-10. Okay, sorry, I apologize.
So
Okay.
this one, I think two of them got it correct lah. Pederus dermatitis It's actually an insect bite lah. The insect bite also is caused by your dwarf beetle.
Oh, what beetle?
That pretty dwarf beetle that looks like orange color, red color, very nice one lah. So it causes necrosis of the skin and then causes severe pain. It's actually you touch it, there's a toxin on the body and then it causes allergic reaction. It's actually allergic reaction to the toxin and cause this lah. So I think the season is over. I don't see Charlie N. So the season is over. I don't see much now. 2 to 3 months ago, I see a lot of all these patients.
What you mean?
Yeah, treatment needs prednisolone and antihistamine. You're right. Usually we need to give steroids together with antihistamine and also steroid cream to reduce the inflammation.
Oh, it's not a beetle lah. It looks like an
It's not a beetle. It looks like an ant. It looks like a long ant-like
like
insect lah.
karanga, like karanga.
It's called Charlie's ant lah. In Malaysia, it's called Charlie's ant. But if you go to Indonesia, they'll call it tomcat. Tomcat.
I've never seen this Charlie ant before.
Yeah, and then interestingly, all this Charlie ant goes to very, very high condo because this fella stayed in 22nd floor. I have many patients who stay in like 15th floor, 20th floor, 22nd floor. So the insect actually fly very, very high up and cause this lah. Usually it's in your bed lah, on the sofa lah. You sit down, you got bitten by it lah.
Oh, I see.
Uh.
I've bitten everywhere by mosquitoes. Okay.
Yeah. But it's quite common one. It's quite common in Malaysia now. You calamine lotion you can use lah, but usually you need steroid cream lah. Hydrocot tak jalan lah. You can use Betnovet or something, Elomet or Dermovet and kind of thing lah. Usually you need to use the stronger one called Betasol, Betamethasone or Mometasone.
If you don't treat it with steroid, what happens?
Oh, it's very, very painful. It's very painful, and then it will cause into some center will become a bit necrotic color lah. But eventually it will clear off lah. It will clear off, no problem.
Oh, very painful.
Betnovet you use full strength, 1%, 0.1% betamethasone ointment, cream or ointment lah.
Oh,
Usually I don't give antibiotics. Usually I just give steroid. But if you have you see that there is sign of infection, then you can use antibiotic. You can give painkiller if the patient is in severe pain, but steroid is a painkiller. So you give steroid, the patient will soothe lah. Oral steroid is acting like an anti-inflammatory. You reduce the pain.
wow, very painful.
Mm.
We go on.
Okay. All right. So this patient presented with this on the leg, on the foot lah, on the foot. What do you think?
I haven't looked at the picture. Okay, anyone?
Betty, what do you think? You always
Yeah.
get a correct diagnosis now. You very kiang already.
Oh my God, I know. I think it's a varicose ulcer. Okay, I don't know. Is it?
Wait for other answer lah, then I tell you.
I don't know lah. This one, diabetic. Okay, maybe it's diabetic foot. I forgot about diabetic foot. Somebody said pyoderma gangrenosum. What
What
is?
is DFU? Ah?
Oh, there's a song, FU something. Okay, never mind.
FU don't no the other two dot like that lah.
Okay, necrotizing cellulitis. Somebody said. Somebody's name is damn odd. Diabetic foot.
Oh, diabetic foot ulcer. DFU is diabetic foot ulcer. Okay. Sorry. I am behind time. I'm not those Gen Z type.
When you say FU, we all think something else. Oh,
Venous ulcer infected DFU. Anything else? Okay, I give you a clue. This ulcer you see is a punch out ulcer. Punch out, punch out, punch out, punch out, punch out, punch out. So multiple ulcer combined into one. Can you see a scar? The scar is whitish. So she had this ulcer before. Then here another scar, here another scar, here another scar. Yeah, this is called vasculitis.
oh,
This is a vasculitic ulcer. So this one most likely looking at this is not leukocytoclastic vasculitis. This is vasculopathy. So the medium vessel get blocked from the usually the medium vessel vasculitis. So this type of patient, you need to do a biopsy, see the level of blockage, see the level of vasculitis, and they need to be treated with immunosuppression together with antiplatelet or anticoagulant. You can either use your aspirin, ticlopidine, your clopidogrel, or you can use your warfarin or any of the anticoagulant because this need
you mean the new
anticoagulation
oral
for a
for
period of time because of the blockage. So you need to release the blockage.
okay, Dr. Ki asked what's the underlying problem?
You need to investigate. This patient, I investigated everything seems to be no underlying cause. It just happens like that. Some of it is idiopathic. Is vasculopathy. Idiopathic one.
Oh, so it's primary. But then,
There's no primary cause one. It's just like that only. Like comes out by itself.
okay, so now that this patient had it and had scarring before, means that
Yeah.
he has
Yeah,
ignored.
this patient has seen me before, cleared off, and then re-come again.
I
And
see.
because it's so infected, I admit her for IV hydrocortisone, IV antibiotics, and then go for wound debridement.
Is there, oh, what did I want to ask? I forgot. Oh, I
We
forgot.
screen for all these. We screen for connective tissue disease, everything screen. We screen for your all these coagulopathy, cryoglobulinemia, all negative lah. All negative.
Is it painful?
Oh, it's very, very painful because of the infection.
Oh, it's not because it's because it's
Vasculitis can be painful lah, but not that painful lah. Usually, is the pain usually comes from secondary bacterial infection lah.
okay. Somebody asked whether it's autoimmune.
Is autoimmune kind of thing lah because vasculitis is always autoimmune lah. But vasculitis can be primary without any underlying cause. We need to find the underlying cause lah. So this one don't have any underlying cause. It's just vasculopathy only lah.
Okay. Next one.
Oh, okay. Okay, this one. What do you think? Looks so nice, right? Being whipped by somebody.
Okay.
Betty would know lah.
I cannot
Betty
lah.
would know.
I don't know. Contact dermatitis. Okay, I think it's contact dermatitis, but by what? Fishnet. Don't know. Jellyfish sting. Oh, jellyfish sting. No, I don't know. I really don't know.
Ayo, Betty, you go diving every time. Jellyfish lah, this one.
How come jellyfish like that? Oh, I have all.
Yeah, this is jellyfish thing. This is really jellyfish thing.
Oh my God, it must be very.
Yeah, because jellyfish got that tentacles. All these are the tentacles.
Oh my God, why it went near? Of course, if I see it, but I have scars of jellyfish. Not.
This is the tentacles. He got it from somewhere Terengganu or something. No, no, no. He got it from Phuket or something.
Yes.
So it's all jellyfish thing. This is whole thing is jellyfish thing. So he came to me, it's much better already. He was treated there already with steroids. So what we do is we just continue on with steroids and then put some steroid cream and then give him some antibiotics. Lor. So
Okay, I
this is jellyfish
it
thing.
now because I've seen the jellyfish, right? The tentacles
Mm.
can be like
Yeah,
me
yeah, yeah. The tentacles can be very long. So these are
very long.
all he touched the tentacles. When
Why?
you touch the tentacles, it'll be like this. He's not scuba diving, he's just snorkeling only.
Oh my God, if I see I run away first.
Yeah, yeah, yeah.
Someone,
So when you see jellyfish, you better run. This is my second or third case already.
no, I want to ask. People ask say pee on it.
Sorry?
Pee on it. When you get jellyfish,
Yeah.
pee on it. Is it?
Maybe lah. These are your traditional folklore kind of treatment lah. But I really don't know lah. For us, it's just have to reduce the inflammation lah. Because jellyfish thing is like contact dermatitis.
Oh, okay. No, I mean I see jellyfish lah, but sometimes, okay, sometimes when I dive, there is no jellyfish that you can see. But you know,
But
but it
when
sticks
you
all over.
yeah.
Like I've got scars everywhere and even on my face.
But let's say this happens in a child, the
Mm-hmm.
first thing you think of is the parents torture the child, no?
Oh my God.
Yeah,
Okay.
you piop, 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 but because this is like a rotan hit by rotan like that.
True.
Yeah, so this is jellyfish, not non-accidental injury.
Okay. We go on.
Okay, this lady came to me with this kind of face. It's very painful. She's burning. She is crying. She cannot sleep. Happens for the last 8 months. Every time she goes under the sun, it will burn, it will itch. She cannot sleep. Very, very severe. What do you think it is? She's not young, she is 60 plus years old, 65.
Not that old, lah, okay.
She's not young lah. I saw the diagnosis acne vulgaris, 65 years old, get acne vulgaris is a bit okay lah, not common lah.
Okay. Somebody say acne rosacea. Okay. Photodermatitis. Somebody's I say CTD, connective tissue disease. Dr. K say irritative contact dermatitis. Okay. Okay,
Okay, this patient, initially I don't know what happened. Went to a few doctors, given steroid oral, steroid cream, steroid oral, steroid cream. Got better, come back again, got better, come back again, got better, come back again, got better, come back again. Eventually end up with me lah. This is acne rosacea. This is steroid-induced rosacea.
oh,
Very severe steroid-induced rosacea. You can see all the telangiectasia, she because of the severe pain, she pick on the skin, she rubs on the skin, she wants it to be better, she put alcohol swab on the skin. All this cause severe irritation of the skin because she cannot tahan. So what I did is I stopped all her steroids. Really stop all her steroids. I give her um, non-steroidal cream. I give her antibiotics, and I give her antibiotic cream. She was crying. She cursed me for 2 to 3 months, and now everything clear lah. So, fortunately, the children and her grandchildren is very understanding. I say no steroids, then means they don't give steroid at all lah. First week she comes 2 to 3 times to see me crying because cannot tahan because the medication all burns. Only after 1 month later, she got better. Then after that, by third month, everything almost clear off. Now I think it's almost 6 months. I stopped all these things already, and then her face is back to normal, mild erythema. So the moral of the story is do not overuse steroid on the face because this patient use too much of steroid already, and then all becomes very dependent on steroid. So this is steroid-induced rosacea, but you can call this also steroid withdrawal syndrome.
Oh,
She is very, very dependent on steroid. So sometimes we try to not give steroid for a long time.
she
So this
was
is
on
steroid
oral
withdrawal
steroid,
syndrome.
you mean?
Yeah.
She was on oral.
Sorry?
She was on
She
oral
was on both oral and topical steroids, and she's
for
on
what?
very, very strong topical steroids. She's not on things like hydrocortisone. She's on betamethasone and clobetasol dipropionate. Because your mometasone, your hydrocortisone doesn't work anymore. So that's why she used it for prolonged period of time. She's used it for months and months.
No, she used this steroid for what initial problem?
Initial, she told me a bit of itchiness, a bit of redness. Use steroid, get better. Then hook up to steroid already, lor.
I think it's very easy to get hooked on steroids, yeah? Because a
Yep.
lot of them, one is that so many of my patients also, they cannot
Yeah, because steroid is very nice to use, ma. You use one time, you got better, then you keep on using, lah. I don't mean you cannot use steroid lah. I am a major steroid user. You know, all the dermatologists, their favorite drug is either oral, IV, or topical steroids. But I think the moral of the story is we need to use steroid with caution lah. With caution, we cannot overuse it. Like for the face, usually I will tell my patient use it for 1 or 2 weeks maximum. It doesn't work, come back to see me.
Yeah. Okay, somebody asked, what non-steroidal do you use for
I
the...
use for this patient I use because she wants the cream type. I give her pimecrolimus lah, pimecrolimus cream. But if the patient can tolerate ointment type, there are two alternatives lah. You can use either crisaborole ointment or you can use tacrolimus ointment lah. Tacrolimus and crisaborole is far more superior than pimecrolimus.
But do you not tail down her steroid use? Do you not use hydrocortisone?
Cannot, cannot. You have to take it off completely. So you have to go
For
to
this,
cold turkey.
you don't even tail down her steroid.
No, no, no. She's on topical, mainly oral as necessary. I don't tell her. She's not Cushing white.
Oh, she's
She's not
not.
Cushing white. She's not Cushing white. She is dependent on topical steroid. You don't use salicylic acid. Salicylic acid will burn the skin. No, no use of salicylic acid. How long can we use tacrolimus? The data for tacrolimus is 52 weeks, but the data for pimecrolimus is children is up to 5 years. The only thing about tacrolimus or pimecrolimus is that it's associated there is a black box warning in the US of possible increased risk of cancer in rat studies. So I usually tell my patient, this I tell them that you have a slight increased risk theoretically of skin cancer, but do not worry. We have used this medication for at least 5 years now without any complication of cancer, and it is only in rat studies. And I say the longest time in studies that we can use is up to 5 years. But if the patient still is worried about cancer, then you use the alternative, the Cristaboro ointment. No?
But can we really trust the US, what they say now? Paracetamol can cause autism anyway.
No, this comes out from US FDA. This don't come out from the politician.
Okay.
This black box warning has been there for the last 10 years or so. US FDA do not want to take off the warning. You cannot use adapalene. How long to use the antibiotic? Usually I use the antibiotic up to 6 months. So I use doxycycline up to 6 months.
Okay, so
But
what,
of course, you can use isotretinoin, but old people, I don't tend to use isotretinoin because isotretinoin is associated with increase in cholesterol and increase in triglycerides. So in older population, I don't tend to use isotretinoin. T3 mycin gel will burn. It doesn't work. If you want, you use topical metronidazole. My favorite is topical Rosex gel lah.
okay, we better go on. Well, today's very interesting, huh? A lot of interaction also.
Okay. So this patient comes with the face like this also on the face. What do you think? What do you think this is on the cheek? This is on the cheek.
Okay. Come on, guys. You're doing very well.
What do you think?
Mala rash.
Mala rash with black comedones. Mala rash. Telangiectasia. This
Telangiectasia.
patient is very well lah. No symptom one. Asymptomatic come to me with this only. Sunburn. Okay. What else? No. This case is a simple case. Redness on the cheek only. No other symptom one.
I got no idea.
Nothing to hide one.
Why got people got something to hide? Slap
The
cheek.
cheek.
What's
Post-inflammatory
post-inflammatory
eczema.
eczema?
Okay, this patient, when you see this with telangiectasia and redness of the cheek, with a bit of comedone here and there, with a bit of acne here and there, it's rosacea lah. It's
Oh,
rosacea. This
this
patient don't use steroid. This is pure rosacea. This is primary rosacea without steroid one.
okay. Hold on.
It's treated like steroid-induced rosacea as well. This is not, she never
I got
applied,
tea as
I
well.
think she never applied steroids lah, but we won't know. Sometimes the cream that you buy online probably have a bit of steroid, especially creams coming from a certain country lah, huh? That one I really don't know. I really don't know. I assume that this patient. So how do you want to treat this? The patients usually will treat with some oral antibiotics. Doxycycline is my favorite one. We'll treat them with a bit of topical antibiotic. And then this patient is very concerned about her telangiectasia. So I do a pulse dye laser for this patient to reduce the telangiectasia lah. After 2 to 3 sessions of pulse dye laser, the telangiectasia went off lah. But I
Okay.
still continue on antibiotic lah.
Okay. Can I ask?
Right.
You have shown us two cases of rosacea.
Rosacea. One is steroid induced, one is non-steroid induced.
Okay, so what is actually rosacea for people like me?
Rosacea, the name of rosacea is called acne rosacea lah, because it looks like acne. There is presence of pustules, papules, something like acne lah. And rosacea basically we think is due to excessive overgrowth of a mite on the face. The name of the mite is called Demodex follicularum. Everybody have the mite. You have the mite, I have the mite. But in patients with rosacea, there's excessive overgrowth of this mite. And this mite will go to your hair follicle, especially the sebaceous gland area, and disturb the sebaceous gland, causing the papule formation. And also it will disrupt the blood vessel, and then it causes dilatation of the blood vessel. So in patients with rosacea, when they are angry, they are under the sun, they eat hot and spicy stuff, it causes all this flushing on the face. They come with you very flush. So this flushing and this thing can also be caused by steroid, because steroid is vasoconstrictor. When you use steroid for a long period of time, this vasoconstriction and vasodilatation occurs very, very fast. There will be reactive vasodilatation. Don't the patient develop a lot of flushing when they go under the sun, or they exercise, or they eat hot and spicy stuff?
Is the nose the one that, is it rosacea?
Yes, rhinophyma is part of rosacea. Eye disease is also part of rosacea.
Is it, it's quite common, is it?
I get it. I diagnose it more and more common nowadays lah. Probably it's common in the past, but underdiagnosed lah. Now, maybe we detect it more frequently now lah. Quite common. I got a lot of girls and ladies having rosacea. I don't know whether I'm overdiagnosing it lah, but I
I
see quite
don't
a
think
lot of
so.
rosacea lah. Uh-huh.
I see. Okay. Okay, let's go on. We've got a few more minutes.
Okay, so this patient comes with hyperpigmentation on the leg. Very, very itchy. She is Indian. So I'm not racist lah, but it's Indian, is hyperpigmented, is plaque, is very itchy. What do you think? This is the profile lah. So if you are Indian, you have plaques, hyperpigmented on the legs, a few diagnoses you can think of only. What do you think?
Okay. Come on, guys, you're doing so well. HIV rash. Okay. This,
HIV not only confined to Indian lah, anybody can get lah.
oh, so this is
Prurigo nodularis,
to
okay.
Indian, you mean?
Tinea nigra. Anything else?
Oh, the Indian is the giveaway.
Yeah. The Indian is the giveaway.
Oh, okay. Okay.
LPP is lichen planopylaris lah.
Prurigo nodularis.
Prurigo nodularis is last time we call it prurigo nodularis is associated with atopic eczema, but nowadays it's a separate disease lah. We want to separate eczema from prurigo nodularis. It tends to be nodular and very, very itchy lah. Capillaritis. Okay, capillaritis tends to be smaller. This tends to be bigger. It's a plaque lesion. Capillaritis, you can see small little dots lah. So the giveaway in Indian is this is lichen planus. In Malaysia, Indian population is the highest population that has lichen planus. So this is hyperpigmented lichen planus.
And it can happen at any age?
You can happen at any age. You can get it when you are younger, or you can get it when you are older lah. But most of my patients, I can see 99% of my patients are of Indian descent lah. You can have Indian descent. Indian descent can be Bangladeshi, you can have Pakistani, you can have Indians, you can have Maldivians, you can have Sri Lankan. To me, these are the South Asians. South Asians has a higher risk of getting lichen planus. Besides that, you can get it in white Caucasian lah. Very, very rarely you see it in Chinese population. How to kill Demodex? You can kill Demodex with doxycycline. You can use Demodex with permethrin. Permethrin is the best to kill the Demodex. So Demodex, you can use it topical permethrin. We do not have topical permethrin in Malaysia, but you can get it in Singapore by the brand name of Sulantra.
Okay.
Okay, so lichen planus, actually this patient has other lesions elsewhere also lah, but I'm just putting the legs. Usually what you need to do, look at the nails also, and then you look at the buccal mucosa. There are signs of lichen planus there. So hyperpigmented lichen planus is common in Indian population, and it not only occur on the leg, it can occur on the face as well. The treatment is with immunosuppression, topical or oral immunosuppression, because it's an autoimmune disease. So oral steroids, topical and oral immunosuppression works very, very well for lichen planus. Lichen planus can be associated with hepatitis B and hepatitis C reactivation. So you need to do blood test for this patient lah. But usually it's racial genetic lah.
Sorry,
Okay, this case, I think after this probably can stop already, right? Or a bit more lah. So you look at this patient. This patient very interesting. He's a Chinese man. He can't tell me that, hey, I got this rash after I go and tembak suatu. You know suatu or not? Babi hutan. Then he said this babi hutan caused him to have this rash. So what do you think? He's itchy. He's itchy. He was admitted to another hospital in Teluk Intan 2 to 3 times, not getting better, and then come and see me. And then he keep on blaming it on the suatu. He go and hit tembak babi hutan and say babi hutan caused this. So this is a new disease caused by babi hutan. What do you think it is? Erythema multiforme. Any other offer?
Okay.
Can somebody describe the lesion for me? You see this lesion, can you describe the lesion for me? Then you describe the lesion, then you will get the diagnosis.
It is
there is a keyword to the lesion. Keyword. I give you the keyword, sure you can get diagnosis one. But I don't want to tell you the keyword. I see who can get the keyword. Bull's eye bukan lah. Salah.
Okay, despite dermatitis.
Nope.
Pityriasis rose. Annular granulosum.
Nope.
Okay. This one last one, please, somebody.
Wheels urticaria. Nope, not wheels and urticaria.
Last one, come on. Okay.
Target lesion, no.
Give a smoke,
Lyme disease, no. Okay, I give you a hint.
Okay.
Can you see blister here? Can you see blister? Blister. How is the blister arranged? Is blister arranged in a
circle,
annular pattern? Can you see? Blister, 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 blister. How does Queen Elizabeth crown looks like? On the top of the crown, there is jewel. So this is a jewel in a crown appearance. So what disease has jewel in a crown appearance?
In the crown.
Last time people describe things like that lah. They look like this, look like a.
Okay, come. What
crown?
Come on, guys.
Yeah, what give you jewel in a crown appearance? You go and Google, you sure can get the diagnosis one.
You non-Google lah, come on. Like that. Hold on,
Okay. This is a condition called linear IgA bullous dermatosis. Linear IgA bullous dermatosis is one of the bullous diseases lah. So I send for HPE, I send for direct immunofluorescence. The direct immunofluorescence shows that there is a deposition of IgA there lah. So this is linear IgA bullous dermatosis. The treatment is just like bullous pemphigoid lah. We give steroid only lah. Nothing special lah, but it's just very, very no relationship with his hand lah. He gila one lah. He keep on telling me that the babi hutan give you this lah.
Okay,
No
so
relationship.
why did he get it?
I think probably the stress
Coincidence,
lah.
is it?
It's probably stress or some infection trigger it to come out. I don't think it's related to his hunt with the wild boar lah.
Okay, hold on. Let me do the sharing of
Mm,
the one. Okay, do one
yeah.
more lah. Just do one more, can Sorry,
One more okay.
Okay, sorry, Cause
All right. This one everybody can get lah.
everybody, I'm not so sure about me lah. Okay, okay.
Can lah. You also can get lah.
Well, I very busy. I need to do this first. This is for doctors. Okay, this is for doctors. Hold on, let me write this first, Okay, this is for doctors. Okay, okay. Oh, wait, hold on. Meeting group chat. Meeting. Can you all see? Doctors. Okay, hold on, And then this is for. Okay, okay. You sorry. Can you see the group chat? The chat? Because I'm very busy here. Meeting.
I can see the chat. I think everybody is correct.
Oh, wait, hold on,
Mm.
Let me see if I can say oh, hold on, Everyone is correct, Okay, okay.
So it's cutaneous larva migrans lah. Yeah, this is caused by hookworm larva. When you go to the beach, you lie down on the beach or you put sand on your body. The hookworm larva of cats or dogs, mainly the cats, will go and burrow into your skin and cause this lah. This is cutaneous larva migrans. So how do you treat? You need to kill off the hookworm larva. So you give all your antihelmintic law. You can use mebendazole, albendazole, and then if you want to do, you can do cryotherapy on the advancing edge lah. You spray the larva lor. So the larva will move 1 to 2 cm per day every day. So the patient will tell you either it's itchy or they feel crawly sensation on their legs lah.
And where will it go to when it
It's a human is a dead end horse. You die. You grow, maybe 10, 20, 30 centimeter, and then you die by itself lah. Because it only will infect the host animal that is correct, either cats or dogs.
Oh, this is when we say
It's nice this one we call it serpiginous appearance lah. Looks like ula go everywhere. The dose and frequency of antihelmin depends on the antihelmintic lah, but I usually a bit kiasu. Your albendazole, I give 400 milligram OD for 3 days lah. Usually state dose is enough, but I kiasu lah, I give 3 days.
Okay. Well, this is the true meaning of you getting under my skin. The true meaning of getting under my skin. Okay, guys. See
So
you.
I think that's it lah. That's it lah.
Next week.
Finish already.
Next week. Next week, I think we have what? I know. I think it's an interesting topic, forensic pathology. Yeah. Okay, bye guys. I'm going to take a rest. Bye. See you next week.
Bye.
Bye-bye.
Thank you.
Bye.
Thank you, everyone. Okay, let me stop the live stream. Okay, thanks, Felix.